Welcome to the Vet Dental Show. I'm Brett Beckman. I'm a board-certified veterinary dentist, and we come to you every week on Wednesday to provide the veterinarian and the technician team some actionable things that you can use in your practice. And this episode is going to be a recorded episode that we've done in the past, not a podcast that we've recorded or not the Vet Dental Show, but actually some other information for you that we know you're going to enjoy. So sit back, enjoy, and we'll see you at the end of the podcast.
When we're looking at criteria for root canal, if one is if the pulp is exposed. So if the pulp's exposed, the pulp cavity is exposed, and the pulp chamber is exposed, then that pulp is either dead or dying. And by exposed, I mean you can put an explorer down into that area. And if that's the case, then if the radiographs are okay, and if the tooth has no significant periodontal disease, then we can do a root canal on that tooth. And we do root canals if you have a lucency in some cases. If it's a case that it's the common maxillary fourth premolar that gets fractured from chewing hard things, where the apex is dramatically affected, and or there is a fistula under the eye, I don't recommend root canal, but some specialists might. I don't do it because I want the patient to be pain-free immediately and not have to undergo additional inflammation since the pulp's out, while that area of inflammation infection clears. I want to get in there and clean it out after I extract the tooth. So that's why I don't recommend that. Some people might, but I don't recommend that if it's severe. So that's one scenario. And the other scenario would be a tooth that has any other radiographic changes that suggest it's dead. You could have a tooth that died when the patient was a year of age and the patient's 4 now and it's got a large pulp cavity. As long as the root tip is still intact on that tooth and there's no severe changes around the bone at the root tip, that still could be a candidate for a root canal. And you pretty much always want to ask the owner if that is something that is of interest to them, if there's a possibility of saving a tooth. And if you don't, it could come back and get you if the owner is not given that option and they find out later that they could have had that option. That certainly doesn't happen very often to my knowledge, but it could, and I'm sure it has. So keep that in mind. Those are there's not a lot of times when we can't, absolutely can't. If there is a fracture under the gum or under the marginal bone level that's a vertical fracture, then those can't be saved. If it is a situation where the root tip is destroyed, and that happens a lot when the pulp's been exposed for quite some time or the tooth's been dead for quite some time, and the byproducts in pulp necrosis or bacteria or both have caused the root tip to be resorbed, then those are not candidates for root canals unless we do surgical root canals, which I generally don't recommend for the patient because it's a lot of involvement for the patient, and those are not 100% or near 100%. Root canal, 95% chance, as long as there's no changes around the root tip that are significant, that it's going to be fine going forward. And Christina asked are all discolored teeth non-vital? No. And yes, if it's an intrinsically stained tooth, then that means that the tooth is either dead or dying, or has chronic pulpitis. And since we don't know if our patients with chronic pulpitis are uncomfortable or not, as sometimes they are or aren't in humans, we would recommend root canal or extraction in that 7% that have that. And that's data from Fraser Hale that did a study in Canada where he took patients that had intrinsically stained teeth and he did root canals on them. And on the teeth that weren't dead, he took the pulp and he sent that in for histopath. All of that pulp was diseased in the 7% that weren't grossly diseased. And by grossly diseased, the pulp was either fibrotic or the pulp cavity was full of black soot, which we get quite a bit with teeth. Any of those changes that would suggest that the tooth is dead fall into that 93% category, where 93% of teeth with intrinsic staining are dead. The other 7% are dying or need or have chronic pulpitis, and all 100% of those need either extraction or root canal. And again, this is a time when we want to suggest root canal to the client, because it's hard to sell a root canal or an extraction on a tooth that grossly is normal. And I would suggest you let them see the x-rays and let them see the changes and let them know what happens if that tooth is left, even though it's not showing x-ray changes yet. It will very likely do in almost every instance, and it will be painful or discomforting to the patient off and on throughout the time that tooth is left in the mouth or does not have a root canal. So I hope that answered your question. If owners are unable to refer for a new root canal, is extraction or continued monitoring the best step? Amanda, if we're talking about a dead tooth, or if we're talking about a tooth that has changes that suggest it's dead radiographically or otherwise, then yes, extraction is the only step if the owners do not want to do a root canal. Megan, good question. We do canines on cats. There are no other teeth that I've done root canals on. I don't see any reason why we would, because most of the time there's never a fracture of any tooth in a cat other than a canine tooth, unless it's from tooth resorption. So you're not going to see cats fracturing the fourth premolar and first molar because they don't chew on hard things for the most part. Maybe in the wild they did when they ate prey, but not in our domestic cats. Michelle, if for those teeth where it looks radiographically okay, is it appropriate to monitor if there's just a little indent in the probe? In other words, you can't get it further into the canal. Yes, and that is the case. And there are, like those teeth that we saw in that case where they were black and there was some indentation. I'm not sure if I mentioned this there, but if it looks like that and there's some indentation, and it's that dark color, in our experience over the years, those are almost always non-vital. So take that into consideration when you're looking. But then again, you saw that case in the same case where we had that big lucency and you had the dark discoloration, and then you had a lot of teeth. All four of those canines were really bad, and then you had the first molar that looked fairly normal, and then you had the first molar that had the big lucency on the mesial root. So you can't be 100% sure on any of those. You always want to radiograph first, but those black ones usually are radiographically just a mess, like those four that I showed you. Feline clients, Carol, that refer extraction of mandibular canine when a maxillary canine is removed, do you monitor the lip? One observation that we've had as a group with our mastermind group, which is the precursor of the veterinary dental practitioner program, is that when we extract those canine teeth, the maxillary canine teeth, any problem with that bottom canine entrapping the lip is usually transient. There may be an indentation there, and there may be irritation, there may be a lesion there, but usually at the recheck in 2 to 3 weeks, that lesion resolves. And we don't check our patients back for routine treatment or extraction. So what we do is what Dr. Jody Reed suggested, and we've adopted over the years, is to take and do a little odontoplasty and remove the tip on that mandibular canine and not get into the pulp canal, but just round it off, make it smooth, and then bond that with a bonding agent. Now, again, you guys don't have bonding agent for the most part in general practice, so that's not something that you would be doing in your practice, but monitoring it to get the patient back in a week. If there's significant changes there, you probably want to extract, but I would not extract just right off because there's a good possibility that's not going to be an issue long term for the patient. But it's good to head it off and do the preventive maintenance with the abdominoplasty and bonding if you have that capability.
I hope you enjoyed this episode. There's a lot of actionable items in there that you can take and use in your practice immediately. So put those to work and enjoy the benefits for the practice lifetime in your dentistry service. So until next week, have a great week. Take care, guys.